My name is Dr. Juarez. I've been in the Valley here for over 30 years and been practicing general surgery and weight loss surgery for the past 20 years. What brings us here today is we're going to learn about what obesity is, what our daily challenges are, what it is costing you, the surgical options, and what are the next steps. So what is obesity? Obesity is defined as lifelong, multifactorial, progressive, and potentially life-threatening condition, and it's a chronic metabolic disease. In other words, obesity can create multiple comorbidities, which are such things as hypertension, sleep apnea, diabetes, and the list goes on and on for probably another 30 different items. What are these conditions all doing to your body? Well, what they're doing to your body is that eventually they're going to shorten your life, because a diabetic patient can indeed require cardiac surgery, can require amputations, and ultimately early death. Hypertension is the same way. You can develop cardiac disease. You can also develop strokes, which again will also shorten your life. And so the idea behind weight loss surgery, it's not only that you're losing weight, but that you're losing those medical conditions, which will put you back on track to live a normal life. And so now, how do we determine who's a candidate for surgery and who's not a candidate for surgery? So first of all, we have to talk about the BMI. The BMI is a measurement of a patient's height divided by the weight, and that gives you a certain number. So the BMI that we're concerned about is the BMI of 40. A BMI of 40 is equivalent to somebody being 100 pounds over their ideal body weight. When a patient has a BMI of 40, most insurance companies will approve your surgery. However, there are other surgical procedures and non-surgical procedures in which your BMI can be as low as 30 and still have a procedure performed that will help your weight. So patients who are candidates for surgery have to have a BMI of at least, as now you know, of 30. They have to have comorbidities. They have to have tried different diets in which they've attempted non-surgical weight loss, and eventually your insurance company will determine whether they will approve it or not. Contraindications are those patients who do not qualify for surgery. First of all, those patients must meet the BMI requirement. If they do not, then they will not qualify. If patients have a poor heart condition, if they have poor lung condition, if they have psychological issues, behavioral issues, smoking or drug abuse, those patients are not candidates for surgery. All right, so we've determined that you are a candidate. You come to our office. So now we'll talk about what your surgical options are. There are 4 options that we can perform. The first option is the gastric bypass, or it's also called the Roux-en-Y gastric bypass. It is the gold standard procedure for this population. There's the vertical sleeve gastrectomy, which is a newer procedure. The gastric bypass has been around since the 1970s. The vertical sleeve has been around for the past 15 years. The gastric banding has been around since 2001, and then the duodenal switch has also been around since the 1970s. Now we'll go through each one of these and describe how the procedures are performed, their effectiveness, and their potential risk and complications. Okay, so let's begin with the gastric bypass. The gastric bypass is, as you can see in this diagram, it's when I create a small gastric pouch from your stomach, and that size of that pouch is about the size of an egg or the size of a golf ball. The intestinal part is performed by dividing the intestine about 3 or 4 feet from the beginning, and one arm of that division is brought up to the small pouch, and then the intestine is reconnected down below to the other intestine. And so this is called a Roux-en-Y gastric bypass because it looks like a Y. How does it work? Well, it works by restricting how much food you take at any meal, and then it works by malabsorption by the intestinal part. But the amount of malabsorption, we really don't know or can't calculate, but we do know that you have enough malabsorptions to the point that once you have the surgery performed, a year later, you'll have lost approximately 80% of your weight. Now, this operation is performed laparoscopically. About 15, 20 years ago, all these operations were performed with an open incision that was about 10 to 12 inches in size. And so this approach laparoscopically improves the outcomes and decreases the complication rate. But what are the complications? The complications of a gastric bypass, number one, is going to be bleeding. That percentage is about 1%. The next complication that's quite devastating, and it's what we call a leak. A leak is when the connections that we perform, if they disconnect or come apart. What happens when the leak occurs? Well, patients will notice that they have low-grade temperature. They'll notice that they have a rapid pulse rate. They don't feel well, and their pain is worse than when they had the surgery. What's important here is that once we recognize that you have a leak, you need to go back to the operating room so that this can be repaired, and you'll receive antibiotics. Your hospitalization will probably be in the range of 2 to 4 weeks, depending on how early and if you have any complications from that procedure. So the overall, what we call mortality rate or death rate from a leak is going to be approximately 0.5%. So it's not real high, but it can happen. The other complications with this surgery are ulcers, nausea, vomiting, protein malnutrition deficiencies, but those are long-term, and those can normally be taken care of with vitamin supplementation. Again, hospitalization is 2 days. Effectiveness at 80% of your weight will be gone in 1 year. All right, let's go on to the vertical sleeve gastrectomy. In this diagram, you can see that we've removed approximately 80% of your stomach. It's also performed laparoscopically. This surgery typically takes about anywhere between a half hour to an hour to perform, and most patients only need to stay 1 day in the hospital. What are its complications? Its main complications are going to be nausea, vomiting for the first 24, 48 hours. After that, patients feel well. They are able to drink easily. They won't experience much in the way of nausea or vomiting. The main complication, as I said, is bleeding, and also 1% risk of a leak at the top of that stomach. This operation, most patients will lose anywhere between 60 and 70% of their weight, and also in 1 year. Now, this operation is preferred by most patients because it's a lot easier to recover. There's very little nausea or vomiting, very little reflux. And so today, I perform about 60% of the surgeries are of the vertical sleeve. So the next operation that I'm talking about today is called the biliopancreatic diversion, or the duodenal switch. This operation, as you can see in the slide, it's much more complex. It takes longer to perform. It ranges between 2 and 3 hours time to complete this procedure. In this procedure, you see a gastric sleeve is part of the operation, but the intestinal operation, you can see that the connection is down in the first part of the intestine, which is called the duodenum, and that's where it gets its name. And if you'll notice the corner on the right, there's a part of the intestine that's called the common channel. So that common channel is the part that is left so that you can absorb all your vitamins and calories. Most patients have approximately 14 feet of intestine, and so you can see that by leaving you only 3 feet, you don't have much intestine to do what it needs to do. And so you will be required to take vitamins and watch the carbohydrates and sweets that you eat, because if patients eat those particular foods, they can develop severe diarrhea. All right, so let's talk about the last surgical option, and this is the lap band, or the gastric banding. This operation, we place a a band on the upper part of the stomach. And the idea behind this is to limit how much food you eat. And also, by placing the band in that position, most patients will feel less hunger and more satiety once they've eaten their small meal. This operation came about back in 2001. It was being performed in Europe and in Mexico before then, but it was approved by the FDA in 2001. It had a great run in the early 2000s, between 2004 and 2008. The majority of operations being done in the U.S. was the lap band. However, lately, because of its side effects and complications, it is now being performed in the range of about 1 to 5% across the country. Well, what were these side effects that led to this? Well, patients, once they had the band placed, if it became too tight, they would have nausea, vomiting, severe heartburn, choking, aspiration, to the point that most patients want the band out. The other thing that also happened is that they report weight loss in the range of 20 to 30%, and that's not enough to take away the comorbidities that we were describing before. So this operation is not being performed very often these days. So the last thing I want to talk about today is the non-surgical option, and this brings us to what we call the Obera balloon. The Obera balloon is a spherical balloon that's placed in the stomach and is placed under an endoscopy procedure. Its indications are for patients whose BMIs are between 30 and 40. So patients for about 40 to 50 pounds overweight can have this procedure. Patients who have had prior gastric surgery are not candidates for this surgery. So you have to have a stomach that is normal, and we can figure this out by doing the endoscopy before the balloon is placed. And once we know that the stomach is in good condition, the balloon is placed under the endoscopic technique. Once it's in the stomach, we fill it with approximately 500 to 600 cc's of saline, and then it's disconnected, and so that the balloon is left in place. We leave the balloon in for approximately 6 months, and at that point, it needs to come out. We need to make sure that it isn't damaged or corroded, because, as you know, in the stomach there's a lot of acid that is produced, and so therefore it needs to be removed. Most patients will lose anywhere from 20 to 50 pounds after that time, and most patients will learn how to eat properly and how to avoid the sugar and the carbohydrate diets that they were on previously. With this system, you also have the availability of what we call a Obera coach. You can speak to somebody about your balloon, about diets, about exercise, and they will help you along, and that's available to you for the first year. So things you need to remember about the balloon: it's non-surgical, you have to have a normal stomach, and the balloon has to be removed in approximately 6 months after it's been placed. Well, thank you everybody for watching the video. I look forward to seeing you in the office and helping you along your journey to better health and a long life.